You guys can see the presentation?
Yes, I can see it.
Okay.
Oh, it seems the webinar has started.
Could we just pause it for a sec while I check if
All right. So we are very pleased to have Dr. Timothy Chan as our speaker today for the Informed Health Application Society online seminar series. So Dr. Chan is the Associate Vice President and Vice Provost of Strategic Initiatives and Professor in the Department of Mechanical and Industrial Engineering at the University of Toronto. His primary research interests are in operations research, optimization, and applied machine learning, with various applications, including healthcare, medicine, sustainability, and sport. He also holds several editorial roles in many academic journals, including a lot of the leading journals here at Inform, such as OR, Management Science, and MSOM. And he served in many leadership positions and service roles, both at Informs and the Canadian OR Society, including a previous role as president of the Informed Health Application Society. Without further ado, Tim, I'll let you go ahead and get started. And we're excited to hear about your work.
All right, thank you. And thanks for the invitation. So as the title suggests, I'm going to be talking about some of the work that I've done over many years, actually, in this area of optimizing the deployment of defibrillators. There's a lot of acknowledgements that I couldn't fit them all on this kind of home screen, on this title screen if I wanted to, but this is really the culmination of the work of many students and collaborators over many years. And this is I think this is the first time I'm giving this presentation, so I probably have a bit more content than we can cover in the hour. So I'm happy to kind of move quickly through some things, but I will try and leave a lot of time for questions either through during or at the end. Okay, so feel free to pop questions in the chat or interrupt me as I go. Okay, so this is a quote from The Hitchhiker's Guide to the Galaxy. I could calculate your chances of survival, but you won't like it. And so this was Marvin speaking about space travel, really. But he could have very much been talking about what we're focused on today, which is cardiac arrest. Okay, so cardiac arrest is basically when your heart stops pumping unexpectedly. It kills, many people annually. Survival rates are very low, typically below 10%. And it's very time. And part of the reason is because it's very time sensitive. So your survival odds fall by up to 10% per minute of delay in treatment. And really, the only thing you can do if someone has a cardiac arrest, their heart stops, they kind of fall unconscious, they collapse on the ground. What you can do is you can provide CPR to that person. So putting your hands on their chest and pushing down to try and manually get the heart going. And you can also try and deliver a shock or a defibrillation to them to basically reset and restart the heart. Okay, and if you can do these promptly, then survival rates can be quite high. The challenge is doing this promptly and getting a defibrillator, getting someone to do CPR quickly. That's the real challenge. Okay, there's kind of a common misunderstanding between what a cardiac arrest is and what a heart attack is. And so these are different things. And I just wanted to clarify that up front. So a cardiac arrest, you can think of it as an electrical problem. So the kind of electrical signal is not telling your heart to pump in a coordinated fashion. And so sometimes it stops pumping, sometimes it's kind of irregular, sometimes the heart is kind of fluttering. Whereas a heart attack, which would actually be a great name for a cardiac arrest, but a heart attack means something different. A heart attack is really a plumbing problem. So in this picture shows there's, for example, like a blockage in an artery. And so an important difference is in a cardiac arrest, you're definitely unconscious and you can't do anything. Whereas in a heart attack or leading up to a heart attack, there's certainly time where you are conscious and you can do something like you could potentially call 911 yourself. Okay, so for a cardiac arrest, what can you do? As I mentioned, CPR. The other thing is a defibrillator. Someone could apply a defibrillator. And so this is some pictures of what we call an automated external defibrillator. So these are very small devices, roughly the size of a laptop, a bit thicker, but roughly that size. And it can deliver an electric shock and reset the heart. And they're actually very easy to use. So the picture on the left shows this kind of 1, 2, 3. You turn it on, you put the pads on the person. It tells you where to put them on. The computer will analyze the heart rhythm, and then and only if the heart rhythm is of a type that is shockable will it tell you to press the button and step 3 and then stand back, and it'll automatically deliver a shock. So you might watch medical TV shows, and they wheel in these big machines to someone at the bedside, put the pads on them, and miraculously save the patient. So those are kind of full or big defibrillators. These are very portable defibrillators that you will see, on the wall at the airport or in a shopping mall or in a sports arena. So they're very portable. You can just grab them and go. And basically anyone can use them. Okay, so what do they look like in the wild? So here are just some pictures I've taken over time of a defibrillator. This is in a desk, like a security desk in the lobby of a high-rise building. These are a couple of pictures of defibrillators at airports. So I think the one in the top middle is Toronto. I think this is LA. There's one in Europe and one in Panama. So they all look about the same, despite kind of being in very different types of airports. There's typically a sign. It's a box on the wall. You just open the door, and then you grab the defibrillator and you run to wherever you need to go. For those of you who may have been to Japan, they really know how to showcase what a defibrillator is. So this is like a standalone little station inside of a train station. So it has kind of a cartoon. It has multiple languages at the bottom. It's really apparent, hopefully, what this thing is. And if you see someone collapsing, you need this. Hopefully, you'll know where to run to go grab an AED, because it's just very prominent. The other thing I think the Japanese do really well around defibrillators is they put them everywhere. So you might know that there's vending machines everywhere in Japan. And so here is a vending machine, and you see in that kind of orange in the bottom left there a picture of a defibrillator inside the vending machine. So you don't have to buy it. You don't have to put money into the machine. You can just open the door and get it. But the amazing thing is it kind of creates that mental association between like the vending machine and the defibrillator. So if someone collapses and you think they might need a defibrillator, you don't have to, in that moment of panic, try and look for one, trying to think about where it is. You might just remember, maybe I just have to go to where the nearest vending machine is, maybe around the corner, and then I can go grab an AED and bring it back to the patient. A few other pieces of technology that I think are quite relevant. So now there are these mobile apps that are basically connected to 911. So if you call 911 and you say this person is collapsed and they're not breathing, and then eventually the dispatcher will, let's say, determine that it's likely to be a cardiac arrest, they're going to send an ambulance, obviously. But at the same time, in cities where this app is live and connected to the 911, it will send a push notification to any person who has this app downloaded on their phone. And it'll basically tell them, here's where you are, right? Here's where someone who needs your help is. Will you please go and run over there and then help them provide CPR? And if they know also where the nearby AEDs are, it'll also show that on the map, so that you might go and grab the AED on the way to running to help the patient. Another piece of modern technology, sounds a bit fantastical, but it is a reality now, a defibrillator drone. So cardiac arrest is really one of, if not the most time-sensitive medical emergency. And so this was a student, an engineering student's master's project in the Netherlands many years ago. And he designed this kind of prototype defibrillator drone, where the idea would be you call 911, they'll dispatch a drone, they'll dispatch the ambulance, they might dispatch the bystanders using the app, but they'll also dispatch a drone. The drone will obviously have the benefit of avoiding traffic and flying there in a straight line. So you'll reduce the time till the defibrillator arrives, and the idea is the drone itself is the defibrillator. So you pull the pads out of the drone. The battery of the drone is actually what gives you the power to deliver the shock. And so that's basically the idea. Even though it sounds crazy, this is actually now in practice. So from the time that this defibrillator drone was developed from 2014 through a lot of kind of modeling work that we were involved in. And then independent of us, drone test flights were already started to simulate cardiac arrest in Sweden. There was some kind of testing in Canada as well here, and now testing kind of all over the place, to the point where this system was live in Sweden. I should have noted that in 2021, the first person in the world was saved by a drone delivering a defibrillator. So this person was, I think, shoveling snow or something, and then collapsed, and someone called their equivalent of 911, and this drone came within a couple of minutes, and the person was able to revive the person with the defibrillator. So a real success story, and quite a quick progression from kind of a concept of an idea to real practice. Okay. So in talking about, I haven't talked about any of my research yet, but I just wanted to set the background, the context. So in thinking about all of these different things that I've mentioned up until now, this idea of like a static AED, so an AED put on the wall somewhere, like at an airport or a shopping mall or something, to the idea of using an app, to the idea of using a drone, I'd like to think about kind of classifying a portfolio of strategies, and that these different types of interventions might have different kind of ranges or geographies where they're most useful. And I don't think this is a perfect classification, but hopefully this gives you an idea, a way to think about it. So static AEDs, I think, are really going to be most useful in like dense urban areas, right? Because they're statically located. Someone has to go run and make a two-way trip, typically run somewhere and run back. And because it's time sensitive, you're not going to be able to run very far, right? So I like to think of these as kind of most relevant for dense kind of urban areas, like a downtown setting. And then in maybe a slightly less dense area, like in a suburban area or like a residential neighborhood, there are these programs called Neighbors Saving Neighbors that are being developed, where the idea is, for example, like an app-enabled neighborhood program. If someone down the street in their home kind of had a cardiac arrest, and someone there called 911, I might have a defibrillator at home, or there could be a defibrillator on my block, and I could get notified, and I could run and go down the street to potentially save my neighbor. Right. And I think the short and medium range are probably, there's a lot of overlap there. And then, but for a long range setting, or for maybe a more rural setting, the idea of, and typically where 911 response is the slowest, just because of how not dense those areas are, something like a drone might be the most appropriate technology. Okay, so I'll just tell you a bit of a high level of kind of the type of research that I've done in this space, and this has spanned probably about 15 years now. It started from kind of, let's call it a basic facility location model, as I started to think about kind of how would we optimize the placement of static AEDs. So all we were really thinking about here was kind of the spatial optimization aspect of it. And then we started thinking about a spatial temporal model. So not just optimizing like a facility location model, not just optimizing where we place it, but optimizing where we place it, considering things like the hours of availability of a building, right? So if you put a defibrillator, let's say, I don't know, in a bank, and the bank is closed at 5 p.m., then you might not be able to access that defibrillator after 5 p.m. So we started to incorporate kind of the time element into it. And then we also thought about kind of spatial optimization, but in situations with like physical restrictions. So whether it's a high-rise building, or whether it's like or like airports, or like underground walkways where there's very specific kind of corridors, you can't just kind of cut across a field to get an AED. There's very kind of specific ways you can move in these buildings that introduces kind of novel physical constraints in your location modeling. So this is, I guess, the kind of the colors match up with the previous slide, but this is thinking about kind of that short range spatial placement of defibrillators. And then when this kind of drone idea came up, my collaborators were wondering, could we start to do some drone modeling? And so that's what we started to do here around drone network design. And so this would be a mix of, let's say, optimization modeling and queuing modeling. So the queuing would be, for example, like thinking about congestion in the system. How many drones do we put at a base to make sure that there's always a drone available to respond? And then from this type of location type modeling, we worked with people to actually think about implementation. So we actually did some feasibility tests and did some cost effectiveness analysis recently. And then also to think about not just the design of the network, like where we place them, but then also dispatching. How would we decide when and what to dispatch the drones to? And then, so that's the long range. And the medium range is something that I think is a bit newer, certainly for me, and I think for the research community as a whole. But thinking about using OR to do volunteer recruitment, how do we optimize the number of volunteers that we try and recruit to this system? Shane Henderson and colleagues have done a lot of really great work in this space recently. And then also similar ideas around volunteer dispatching. How would we know when to dispatch volunteers to cardiac arrest? Okay. So I'm going to, the remainder of the talk, I'm going to only focus on a couple of projects, and they're going to be very short kind of vignettes of the projects. I won't go into a lot of depth, but I'll just give you an idea about them. And so I'm going to focus really on these two areas of kind of the spatial modeling, the spatial temporal modeling in one case, and then kind of the drone work that we've done in the other case. Okay. So yeah, the outline for the remainder of the talk, a few project vignettes. I'll try and summarize kind of the spatial work and some of the drone work with some of the practical impact that we've been fortunate, I think, to have over the last few years. And then also wanted to share how the work in this area has helped actually open new doors for research that led to kind of other applications or even new methodology that we hadn't thought about at the beginning. And so sometimes working on a very concrete problem, you never know where it's going to take you. And sometimes it takes you to some really interesting new directions. Okay, so this first topic around spatial temporal optimization. Before we had worked on this, most research had really focused on spatial factors. So thinking about spatial location, and there had been fairly limited study of temporal factors at the time. When you look at the guidelines from the American Heart Association, they would say things like, we should place AEDs in public locations where there's a relatively high likelihood of a witnessed cardiac arrest. But there was no mention of, kind of the temporal availability of the AED. And so a couple of questions that we and other groups had looked at was, number one, how much is AED availability overestimated when we don't consider building hours of operation? So there was a great study out of Denmark that basically found that about half of the time an AED was unavailable when you really needed it, even though you think it's available because it's only 50 meters away, but it's behind a locked door and you don't know until you get there. So that first question is, trying to figure out true availability, and are we actually overestimating availability? And then the second thing is, assuming we are overestimating availability but not considering temporal factors, how do we modify a spatial model to include these temporal considerations so that we can place AEDs more effectively? Okay, so just to give you an idea about just some data around cardiac arrest. So this was a data set from Toronto, about 2,000 cardiac arrests. And we split the cardiac arrests by a daytime, evening, and nighttime. So daytime was, I think, 8 a.m. to 4 p.m. Evening was 4 p.m. to midnight. And the nighttime was midnight to the next 8 a.m. And so you'll see some important differences in some of these variables. So what fraction of cardiac arrests were witnessed by a bystander in the daytime versus evening and night? So in the daytime and evening, it's about 50%, but overnight it drops to about 30%. What fraction of cardiac arrests receive CPR from a bystander? It goes from about 40+% down to 30% at nighttime, so quite a significant drop. And another important consideration is what fraction of cardiac arrests have a heart rhythm that is shockable, that you can actually save with the defibrillator. So it goes from the high 30s in the daytime and evening to the low 20s at night. And then finally, if you look at survival, you go from about 15% to about 10%. So quite a significant kind of temporal change, right? And so to look to kind of match up with the cardiac arrest data, we wanted to look at the AED data. Are AEDs equally available across daytime, evening, and night? And the answer is no. So AEDs tend to be if you just look at the black bar, AEDs tend to be, much more available in the daytime compared to the evenings, compared to overnight. So the proportion of AED of the time that the AEDs are available drops to well below 40% when you get to nighttime. And so we calculated this metric called coverage loss. So if you think about cardiac arrests that are covered, in this case, we mean, think about a facility location model where you have like a 100-meter radius. So what fraction of cardiac arrests are within 100 meters of an AED? If you assume the AED is always available, you get a certain number. So that's the black bar. And if you look at the time of the cardiac arrest and the time that the building was open where the AED was placed, right? So if the AED was in a building that's open from 9 to 5 and the cardiac arrest happened at noon, then we call it covered. And if the cardiac arrest happened at 6 p.m., the building closed at 5, so that we would consider that not covered, right? And so that difference is that between the black bar to the blue bar, where we assume the AED was available 24/7 versus we look at the actual time that building was open. And basically what you see is about 1 in 5 cardiac arrests are within 100 meters of an AED. That arrest happened at a time when that AED was not available, right? So there's about a 20% loss in that coverage. And it's not that bad during daytime because, most buildings are open during the daytime, but it's quite significant at night where, for every 2 cardiac arrests that happen close to an AED, one of those 2 will not be able to get that AED because that AED is, in a building that's closed and locked. And so, understanding that there's this coverage loss, we basically developed an optimization model that tried to account for availability of kind of the hours of the building. And so that's where the spatial optimization model comes from, right? So what is the improvement potential if we can deploy these AEDs with prospective AEDs with knowledge of the building hours? And what we did is we compared this spatial temporal model with the spatial only model to see how much improvement we could get. And it turns out that improvement is quite significant. So across kind of, these n values, where n is the number of AEDs you deploy, the incremental number of cardiac arrests that you can cover, like actual coverage, like accounting for time, was significant across all n. And just if you wanted kind of a summary number, it's about a 25% increase. So if you think about before, the coverage loss was about a 20% coverage loss. So from 100, we go to 80. But from 80, if we can improve this coverage gain by using the spatial temporal model by 25%, that 80, actually 25% of 80 is 20, so that 80 goes back up to 100. So by using this spatial temporal model, we can almost exactly reverse this coverage loss that we see from how AEDs are currently placed. So that was the first project that we did in this space around kind of spatial temporal modeling. And so this second topic kind of builds on the last one, where our research and others looked at where and when to best place defibrillators, but what we were really looking for was some way to try and prove that we were doing better than kind of existing approaches. So kind of on a computer simulation model or in an optimization model, we could show that coverage is better, but could we somehow go back in time and show that if they had placed AEDs using our model, certain outcomes could be better, right? And what would be the gold standard for doing a comparison like this in the medical realm? It would be something like a clinical trial, right? So you would want to, so for example, hypothetically pick 2 cities that are identical in all respects. One city you deploy AEDs according to some kind of organic approach, however they do it. In the other city, we will place AEDs using optimization. And then we observe over some period of time, and then we see which one does better, right? Like that's how you would compare like a drug and a placebo, for example. And so to design a clinical trial like this, you'd have to think about all of the factors. Well, you'd want kind of the same number of AEDs in the 2 cities. You'd want to find, you'd have to find 2 cities that are very similar. So there'd be some sort of geographic control compared to the city where you're actually implementing your optimization. You would need to observe for a long enough time so you get a large enough sample size. So that involves the trial duration, and you'd want a clear outcome measure. For example, like how many more people survive, let's say, when you have the optimally placed AEDs versus the alternative, right? And so, like with any clinical trial, but maybe particularly one of this nature, there would be very significant challenges, right? So there'd be cost, deploying lots of AEDs. The length of time that you'd have to be doing this would probably have to be years, and obviously very complicated logistics of making a trial like this happen. And so it got us thinking, like, could we do some sort of an experiment in silico, like a clinical trial in silico, to really look at what a counterfactual would have been when if we were to optimize AEDs on the computer, essentially. Okay. And so in order to do this, we worked with collaborators in Denmark who had really good data on cardiac arrests, but more importantly, they had really good data on exactly where and when their AEDs were actually placed over about a 10-year time frame. And so we could actually go and do this experiment, and I'll try and visualize it. So I'll talk about two timelines. So the first timeline is this kind of control experiment. So this is what happened in reality. Okay. So in reality, cardiac arrests were happening over time in Copenhagen. Okay. And defibrillators were being placed, however they were being placed in time at certain locations. Okay, so we have all of this information, when these events happened, when the defibrillators got placed, and also where. Okay, and based on the timing of the cardiac arrest, based on when the AED was placed, we could calculate things like coverage, for example, right? Was a cardiac arrest historically within 100 meters of an AED after that AED was placed there? Right? And it was open and available and so on, right? So we could calculate these things, can also calculate things like survival, because they track that information, okay? And so now the thought experiment is, in this hypothetical timeline, our intervention timeline where we do optimization, we'll use the same sequence of cardiac arrests in the same locations, but we go back to the beginning of time, and instead of placing defibrillators how they were actually placed, we would use our model. Okay, so how do we do this? Well, let's take the timeline and let's chop it up into time periods. Let's call each time period 1 month. Okay, so at time 0, the 1 will be 1 month later, the 2 will be 2 months later, and so on. Okay, so at time 0, what do I know at time 0? All I know at time 0 is the location and the times of where the cardiac arrests had occurred up until that point in time. So the idea would be, in reality, we know 2 AEDs were placed during that first month. So if we knew at time 0 the locations and times of the cardiac arrest, and let's pretend we are going to place 2 AEDs, well, we'll use an optimization model to decide where to put those 2 AEDs, and let's put them, let's say, at the end of month 1. We'll put them at the optimal locations at the end of month 1 to be conservative, okay? And so the key here is that we're not cheating in the sense of we're not looking forward. We're not using any other kind of future information to make this decision. All we know is where and when the cardiac arrests happen at time 0, and using that information, we'll place AEDs at the end of the next month. And then we just roll this process forward. At month 1, we'll know the locations and times of all of the cardiac arrests up until the end of month 1. We'll also know that we put 2 AEDs at the end of month 1. And then in the next month, we'll place 1. So that will go into the optimization model, and we'll put 1 AED somewhere at the end of month 2. Okay, and then we just repeat at the end of month 3, at the end of month 4, and so on. Okay, and now we'll measure based on the actual cardiac arrests and where they occurred and when they occurred, whether or not they were covered by any of our kind of optimally placed AEDs, right? And you have to believe that the placement of AEDs does not cause, cardiac arrest distribution to change. Hopefully that's a believable assumption, right? And so based on this, we can hopefully calculate new for these cardiac arrests, the kind of new coverage values, and hopefully this number will increase. Okay. Some of the trial design parameters we can play with, for example, we were conservative to put AEDs at the end of the time period. You could try and match it with when they were actually placed in reality. So these are things we could vary in a simulation. We could also vary the time period, right? Instead of it being 1 month, maybe it's 1 week, maybe it's 6 months. And so these are all things that we can test, and which we did test. So So that was the idea. So here are the kind of details behind the experiment and the results I'll show you in a second. So we looked at a study period from October 2007 to December 2016. The reason was that was basically the time at which this Danish AED network was started back in 2007. So that's when they actually started to place AEDs and record in their registry the locations and the dates that they placed them. So the control will be the real placements. The intervention will be us placing an equal number of AEDs in optimized locations under two different interventions. So one will be using the spatial temporal model, thinking about considering the building hours of operation and where we would place them. The second model would be actually even a bit more optimistic to say, let's pretend we place them, let's say, on the outside of buildings, so that even if the building closes at 5 p.m., the AED could be available, 24/7. Okay, so that would be kind of an optimistic approach. But nowadays, a lot of AEDs are being placed outside of buildings that really have 24/7 coverage, based on some of the research that showed that availability was really poor if you kept them inside of buildings. And so the primary outcome that we are going to measure here is cardiac arrest coverage, OHCA coverage. So that's the number of cardiac arrests that occur within 100 meters from an available AED after it was activated, so after that AED was placed. So you notice here the major limitation of this study, of this approach, is that we cannot measure a real clinical outcome. We can't measure whether or not a person would have survived. We can't measure whether or not a person would get even resuscitated on the scene. All we can measure is something that is unambiguous, kind of computationally, which is this distance measure, right? And then I'll show you some kind of modeling later on where we can kind of convert coverage to real clinical outcomes of interest. But I think it's important to acknowledge that this is, I think, the primary limitation of this approach, right? It'll never replace a clinical trial because we can't measure that real clinical outcome, but it's much cheaper and we can get a sense of whether or not optimization will really be better. Okay, so here are basically the results. So starting from October 2007, the AEDs were being placed, and then this blue line indicates cardiac arrest coverage. So what the number of cardiac arrests that were covered that were within 100 meters of an AED. Okay, and so by the end of this period, about 20%, 22% of cardiac arrests were covered by one of the AEDs. Okay, the real AEDs. If we had gone back in time to 2007 and, without looking forward, optimized the placement of our AEDs, considering building hours of operation, so let's say putting them on the insides of buildings, coverage would have gone from 22 to about 33%. So we would have covered, about 80 additional cardiac arrests. And if we had optimized AED locations and put them on the outside of buildings, and so they're available 24/7, we get to about 43%. So between a 50 to 100%, almost the doubling of cardiac arrest coverage. And so to me, this is quite significant in the sense of, like, we're not spending any more money, right? We're putting the exact same number of AEDs, and we're not cheating by looking at kind of future data. It's knowing what we knew at that time. If only we used optimization, and these are very simple optimization models, we could have had a much greater coverage of cardiac arrest. Now, that doesn't necessarily translate to usage, doesn't necessarily translate to survival, but certainly you won't be able to use the AED if it's not nearby. So this is kind of a first necessary step for increasing survival. Maybe in the interest of time, I'll kind of go, I might skip this part, but basically we did some analysis with some kind of regression modeling to try and relate coverage, increase in coverage, to increase in survival or increase in bystander defibrillation. We account for a lot of confounding variables like age and sex and shockable rhythm and so on. But basically, we use a logistic regression model to do this. And the takeaway, though, is that the increase in coverage can lead to has the potential to lead to significant increase in the number of cardiac arrests that get bystander defibrillation and the number of cardiac arrests that lead to actually survival at 30 days. Okay, but again, these are all predicted outcomes from a model. Okay, So that's going to be it for that first half, just talking about kind of static AED placement. Some of the practical impact, I guess real practical impact we've had since this research was done. We've continued this collaboration with our Danish colleagues, and a couple of years ago, they reached out to us and said they had a kind of a donor want to give money to place several, almost 300 AEDs in northern Denmark, and they said, "Hey, could we use your models to actually figure out what the optimal locations are?" And so we worked with them. We used our models. We kind of placed these AEDs over I think a year or two, and now they're in place. And now we're going to kind of go through an observation period to see are there better outcomes from these AEDs that we've placed in northern Denmark. Another impact is with collaborators in Scotland. They really wanted to develop a tool to visualize kind of this type of research so that they could work with their policymakers and decision makers to influence where they would actually place defibrillators. And so I had a student work with a collaborator in Scotland and spend a lot of time over there. And eventually we developed this tool called PadMap. So you can go to it now, padmap.org. And you'll see kind of a map of Scotland. You can zoom in and zoom out, and you can zoom into different regions, and you'll see the locations of cardiac arrest and so on. And our model will recommend kind of locations for where you could put defibrillators. And they've already started to kind of place defibrillators. And again, we're going to do some sort of observation to see if the optimally placed defibrillators kind of can be shown to be a bit better in terms of either coverage or other outcomes. So this has been pretty exciting, taking, I think, fairly simple kind of optimization ideas, but after a long period of time, really working with the practitioners to get this in use. And then just one note around opening new doors, right? So the opioid epidemic, right? So when people get an opioid poisoning, an opioid overdose, again, how do you potentially rescue someone? So you could potentially give them naloxone. So this will help revive them, or has a chance to revive them. And so we were talking with collaborators in BC and British Columbia on cardiac arrest, and then we started talking about this problem as well. And we said, hey, this is actually a very similar problem, right? Like, could we place naloxone kits using optimization so that they would be pre-positioned to be available for people if someone nearby had an opioid poisoning and we needed to go rescue them. And so this is just one figure that we took from this paper that we published recently on this, where if you look at all of these green dots are, if you look at different types of businesses like pharmacies or like pharmacies and drugstores or restaurants or coffee shops or things like that, if you just put naloxone kits kind of everywhere, or supermarkets, right, this would be kind of the kind of level of coverage you would get as a function of the number of locations that you place them. And that dotted line at the bottom is essentially random placement at transit locations. So if you were to blanket place them at chain businesses, you're actually not doing much better than kind of random placement at transit locations, which are everywhere. The few other dots, I guess one other dot of note would be the hash mark, the pound sign. So this would be blanket placement at THN is take home naloxone kit. So there are places that actually distribute kind of take home naloxone kits. And we said, what if we just kind of put blanket placement of these portable naloxone kits that could be used for anyone coming in off the street just to grab one in an emergency. That's where the performance is. But then that solid blue line at the top is if you used optimization, basically. So if you just use the simple optimization model to place naloxone kits based on historical opioid incidents at transit locations, only placing naloxone at transit locations, that's the level of performance you get. And you can see it's a significantly outperforming kind of these existing methods or these hypothesized methods. And the dashed line right underneath is kind of a greedy method. So if you were just to rank order transit locations and you just did it greedily, which would be actually very easy for a policymaker to implement, you get pretty good performance. But if you did proper optimization, considering overlap and things like this, you'd get even better performance. So this was really interesting to see, and this was quite well received from the medical community because it was very novel from the kind of perspective of people studying this problem. But the ideas from the AED work that we did were very directly translatable to this problem. Okay, so I can pause here if there are any questions that people have, or I can keep going.
Feel free to put your questions in the chat. While people are thinking of questions, I actually have a few of my own.
Sure.
So in the optimization model for, I think you said it was a facility location model. Was it a sequential decision-making model? Or was it kind of just like a myopic model, or I guess maybe like a stationary model or something like
that? Myopic. It was a myopic model. Basically, we were kind of doing this rolling horizon, kind of forward rolling IP model. So yeah, this was not like an MDP or anything.
Got it. And I assume the objective was like to maximize coverage, or?
That's right.
Okay.
That's right. Yeah.
I'll give another second here to see if anyone else wants to put a question in the chat. Or there's also like a Q&A panel if you can't write in the chat.
And if there's not, that's fine. I can keep going, and then if people want to interrupt me later, that's fine.
I have a question, actually.
Sure.
For the optimization model, you said the objective function is maximum coverage. Even the survival rates are incorporated to the optimization model, or just standalone predictions done later after optimization are done for the outcomes?
It would be, yeah. So for the models that I showed you here, it was more separate. There's this thing. So we're really focusing on kind of that physical coverage, and then using models afterwards to relate coverage to outcomes. Some of the later work that we did was trying to kind of get that predictive relationship kind of directly embedded into the objective function. But for this work, it wasn't there.
Sure. Thank you.
Okay, why don't I keep going then? There we go. Now I'll switch gears and talk about some of our drone work. And so here the idea was, soon after this drone prototype had been developed, and we were thinking about, okay, well, far in the future, maybe we would have not just a single drone, but maybe a constellation or a network of drones that would be that could be used to speed defibrillators to cardiac arrests. But as we started working on this, a lot of other use cases came up, like kind of like this naloxone and opioid case, right? You could imagine a drone bringing naloxone. You could imagine a drone bringing an EpiPen if it was an allergic reaction. You could bring like a stop the bleed kit if there was a car accident, like a major vehicle in a car accident, and you need like a trauma kit of some kind. So the idea of like a comprehensive medical drone now is actually kind of in development. And so anyway, when you were thinking about that as a motivation for, in the future, there could potentially be these kind of medical drones flying around. And so we would think about, well, maybe we should try and optimize, where we place these drones to maximize coverage, to minimize response time. So the optimization is the number of drone bases and the location of the drone bases. And we also have to think about a queuing component, because as the kind of like ambulances, right, the drones will go out on a mission, they might be busy, and so there might be congestion. So we should think about how many drones we actually need to locate at each base in order to meet a certain service level, right? Like we want it available 90% of the time or 95% of the time when a call comes in. So just to make very concrete, right, what's the kind of comparison between a drone and an ambulance, right? Let's say the call is received at a certain amount of time. It takes a certain amount of time for the dispatcher to triage and decide, okay, now I'm going to dispatch the ambulance. And then the ambulance gets dispatched. They're going to drive, and then they're going to arrive on the scene. And so that total time is this 911 response time, is what we typically think of as the 911 response time. Okay. For the drone, it's a little bit more complicated. So let's pretend that the drone system is integrated with 911. Someone calls. The dispatcher has to go through that same process, right? And then when they dispatch the ambulance, when they think it's a cardiac arrest, they'll dispatch the ambulance, and they'll say, okay, at the same time, why don't we dispatch the drone or dispatch the volunteer responders and so on. So you dispatch the drone. There's a certain amount of flight time that it needs to get there, And hopefully, obviously we're not doing this if the flight time is longer. So hopefully the flight time is shorter than the drive time, which is, I think, reasonable in most situations. But then there's all of these other factors. There's a certain amount of time that the drone is on scene, and then it has to fly back, and then the drone might have to get reset, like check for damage, maybe check for the kind of battery life, maybe swap out the battery and reset it before it's ready to be dispatched again. So when we think about a queuing perspective, like this entire time from dispatch to being ready for dispatch has to be considered for the drone, right? Although when we kind of think about the response time, we're only thinking about call received to arrival on scene. Okay, so we did this modeling in Ontario. This is a picture of so you see Toronto at the bottom there. That's this kind of shape, this kind of rectangular kind of shape here with most of the blue dots. That's Toronto, but we looked at a very large region of Toronto consisting of these 8 smaller regions. The total number of people in these 8 regions is about 7.5 million people, total 10,000 square miles. From 2006 to 2014, the time we did this work, there were about 50,000 cardiac arrests that were recorded in this area. So those are all of the red dots. One of the main reasons for considering drones is that most cardiac arrests actually occur in a private location. So all of the static AEDs that we think about, putting them in malls and airports and so on, those are public locations, and those are the vast minority of cardiac arrests. So most happen in some sort of private location, and those have the worst survival. And so this is where a drone potentially can have the most value. The other the blue dots, are where the 538 paramedic, fire, and police stations were at this time in these regions. And so our initial idea was we needed potential locations to put the drone bases. And so we would essentially co-locate the drones with these paramedic, fire, and police stations. So I won't show you the details of the modeling, but if you're interested, I'm happy to tell you. But there's some optimization modeling, there's some queuing modeling here, but here's one of the results. So here's one particular network of 23 bases in these 8 regions, and in total they have about 37 drones. So some drones like in Toronto, some bases like in Toronto might have 2 drones per base. Some drones in a more rural area of Muskoka might only have 1 drone per base. Okay, but here, this example network can reduce the median, again, based on the data, could reduce median response time by about 1 minute, could reduce the 90th percentile response time by over 6 minutes in some regions. And if you were to simulate and compare how often does the drone get there before EMS, it's about 2/3 of the time. Okay, and so when you say, median response by 1 minute, maybe doesn't sound like a lot, but median response is roughly 6 minutes, longer in some of the more rural areas, but it's been about 6 minutes in Toronto consistently for about 10 to 15 years. So like that response time kind of distribution hasn't moved. Now, I mean, I think that's to Toronto EMS's credit because volumes have continued to go up and they've obviously put more resources in. But the bottom line is it's very difficult to move the needle in reducing response time. But there is the potential here with drones to actually get, life-saving treatment to a victim ahead of time, ahead of a traditional response. And so just a few more distributions to show you the potential improvement. So let's look at Toronto, which is an urban area, the top left. So that's the historical response time distribution, right? Median is about 6 minutes. The 90th percentile is over 10, maybe close to 11 minutes. If we look at a network that aims to move the median by about a minute, so going from about 6 to 5, or I guess that's a bit closer to 2 minutes, but anyway, roughly a minute, right? We can with those 23 drones, or with a few drones, that previous the network that I showed on the previous slide, we can move that thing down by a minute, and the 90th percentile, most importantly, goes from about 11 minutes kind of down to 6 now. So a huge improvement in the tail of the response time, and we can build networks that have more and more drones, and we can move it by 2 minutes. We can move it down to 3 minutes. That 3-minute network, right, moving the median by about 3 minutes, can move the 90th percentile by, over 6 minutes. So you really kind of chop off the long tail of the distribution, which is actually quite important from an equity perspective. And if you look at something like Muskoka, which is a very rural region, these are like kind of where people's summer vacation homes are. You're kind of at the cottage or at the lake or something. So response times you can see here can get up to 30 minutes. And certainly if you're waiting if you have a cardiac arrest and you wait 30 minutes for an ambulance to get there, you're certainly not going to survive. And even in this case, the 90th percentile is at 20 minutes. So even at that point, it's very, very, very unlikely that you will survive. And so again, with these drones, we can actually bring that 90th percentile distribution down and the median quite significantly. So the 90th percentile with a modest investment in drones could go down, can be cut in half. 10 minutes is still long for a 90th percentile, but the bottom line is we can actually move the distribution quite significantly with drones. And so this led to a lot of follow-on research where we are thinking about cost effectiveness. So it's still a bit of a hypothetical. Like it is in use now, and a lot more jurisdictions are thinking about developing drone networks. This question of cost effectiveness has not really been answered, has not really been tackled. And so what we did was we developed lots of drone network designs using a variety of optimization methods. And then we did a fairly, I think, standard but comprehensive cost effectiveness analysis. So with a drone, it's going to have earlier response time in theory. And so we need some way to predict, what does an earlier response mean in terms of outcomes. And then assuming you get a certain outcome, we have a Markov model to predict the patient trajectories post-arrest. And so just to give you an idea, to think through the decision tree, you get a cardiac arrest. The drone either gets there first or the EMS gets there first. And if the drone gets there first, there's some probability that the drone is used or not used. And if the drone gets there first and the drone is used, then you initialize this Markov model with this predicted outcome. But either if the EMS gets there first or the drone gets there, but the drone AD is not used, you go back to the base case where you have this Markov model, but you use essentially the historical data, right? As if the drone wasn't there at all. And so that's what we're trying to compare, the outcome of this Markov model when the drone is used compared to when it's not. And then the Markov model, I won't go into detail, but we basically kind of model kind of neurological outcome, and we kind of accumulate costs, in-hospital costs, post-discharge costs, and quality adjusted life years, and so on, using data from the literature. So we generated close to 1,000 different drone network designs. And then this graph kind of shows like what is the incremental improvement in quality adjusted life years gained as a function of the incremental cost that would need to be incurred to get these improvements. And we can look at this trade-off, and you can kind of plot this Pareto frontier, which is that dashed line, which shows, for a certain cost, what is the maximum kind of quality you're going to get. And so for the subsequent analysis, we focus on these 20 kind of drone networks that are on this frontier of the distribution. And basically what we can show is that all of these frontier networks have a positive net monetary benefit. So the kind of incremental benefit will outweigh the incremental cost, regardless of what willingness to pay threshold. Like if it's a $50, $100, $150,000 willingness to pay for an extra quality adjusted life year, it's always cost effective. It always has a positive benefit. Yeah, so this was, I think, the first paper to really comprehensively address this problem, considering all of the relevant costs. And we're hoping that this provides some motivation for kind of further developing this technology going forward. Some of the practical impact that we've had, after we did our modeling, we were working with collaborators to do pilot tests in Ontario. So out in a rural area of Ontario where this is a simulated cardiac arrest. So, we simulate making the call, someone showed up, was doing chest compressions that you can see there. And then the drone flies from the base to the spot. This was a different drone that we were using in the past, but this drone basically drops the defibrillator, someone runs over and grabs it, and then brings it back to the patient. So this is the idea of how it would work in practice. Other versions of this drone might drop the defibrillator on a line, like on a fishing line, and so on. And so it's kind of a theoretical idea. It's been now made practical in Sweden, and now we're actually going to go live with some kind of real drone pilot in Ontario pretty soon. And we also, through this process, got to meet people at Duke University who are doing this in North Carolina, and we've been working on doing the modeling with them, and they were actually going to start the pilot tests very soon over there as well. I know I'm running out of time, so I might just go, I might just kind of skip this part, but this was an example of doing this cost effectiveness analysis, kind of thinking through kind of new methodology to do cost effectiveness. And so I'll kind of skip this, but basically this led to some kind of interesting kind of new mathematical approaches to do cost effectiveness analysis, which I'm happy to tell you about later on if you're interested. Anyway, so I'll just conclude here. So I think this has been a really fun journey. I've had some really exciting collaborations that have moved, these theoretical ideas, I think, to reality, and that's been very rewarding. I think, one piece of advice for people who might be thinking about doing these types of collaborations, that really try to invest and learn to speak their language, go to attend their conferences. I'm in Vancouver right now, and just came out from a 2-day conference kind of related to cardiac arrest, and I was one of 2 OR people, the other person being my former student in the room. And everyone else is like a paramedic or a cardiologist or an anesthesiologist or whatever, just really talking about what we can do. So I find this really valuable to identify the real problems that practitioners care about. But hopefully, as you can see, that there are lots of interesting OR problems. And as you start to work on the clinical problems that the practitioners care about, I think over time you will, if you're patient enough, be able to see kind of good OR problems coming out from them as well. Okay, so I'll stop here. Thanks.
Thanks, Tim. So we actually do have a couple questions here. So I'll start and ask the first one. It says, if a drone is sent to deliver an AED, will the EMS team still be dispatched in all cases?
Yes. So the answer is yes, they will. So you will dispatch the AED as well as the ambulance. And it's mainly because you still want professional treatment for this person. So a bystander could use the AED, could, in the good case, deliver CPR and shock this person, but this patient will still need to be transported to the hospital. The EMS team might get there and take over and kind of provide more professional treatment and so on. So yes, they will still be dispatched too.
Awesome. And then the second question we have here is about future work. Have you heard of like a similar response need for patients with type 2 diabetes? As far as I know, if someone with type 1 diabetes, if someone with type 1 diabetes suffers from low blood sugar, for example, they might collapse.
That's a good question. I haven't heard about that use case, but I suppose that could also be. I don't see why that wouldn't work. I'm trying to think like what you're going to deliver to this patient. You're going to deliver a box of Oreos or something. No, but no, you're right. I think you could. I think that could work as well. I mean, I think that in conjunction with kind of, people are developing like wearable technology now to detect falls or to kind of detect cardiac arrests as they happen. So, if you can detect it quickly and then, deploy a drone or something kind of quickly to bring some sort of life-saving treatment, I think that could definitely work.
Excellent. One more question here. In the cost effectiveness analysis, does the change in cost reflect a reduction in care costs per unit of time saved in receiving AED treatment? I imagine it's difficult to isolate the effect of earlier AED use, since differences in EMS arrival times could also play a role.
Yeah. So we did try and model very as faithfully as we could the change in cost as a result of receiving the AED treatment. And in a way, you are actually incurring more costs because it's actually cheapest for the health system for that patient to die, unfortunately, right? If they survive, there tends to be many more costs that are incurred, like in hospital costs, kind of post discharge costs and so on. But the bottom line is, yes, all of those kind of downstream costs are taken into account when they receive AED treatment.
There aren't any other questions in the chat at the moment. There's a thank you from from the attendee. Sorry if I butcher your name. I think their name is pronounced Yue. I did want to ask kind of a question on the, I guess kind of one that's kind of a broader, like maybe useful question for people who are just starting out as faculty or starting their own research group. But it seems like these research problems that you worked on started kind of with a more like practical question in mind, and then it's kind of expanded out to in some cases more difficult methodological problems, or kind of just a more difficult variation of the same problem as technology developed. So how do you kind of scope that difference or that balance between like theory and practice as you're getting started, and how does that evolve as you build depth in the area?
That's a great question. I actually see Mike Carter is here on the call and the Zoom as well, and I really want to give a shout out to Mike in that I only got started in this research area due to a connection through Mike, and Mike introduced me, and it's been a very fruitful collaboration ever since. So thank you, Mike, for that many years ago. And it's connected to your question again, that it really does start with kind of that clinical problem, meeting the clinical collaborator, really trying to understand what they're trying to achieve. If you think about your research as a bit of a portfolio, right? The kind of clinical problems and the real practical stuff that they care about, those I would tend to work on to build that collaboration and then publish in, let's say, a medical journal that will have a much faster turnaround time and will actually get read by people in that field. And then I think oftentimes those initial questions, I think those initial questions are very unlikely to be kind of necessarily very deep, challenging mathematical questions, right? They're a very practical question that they would like answered, and there's a very kind of concrete outcome that they're looking for. But I think in the process of working on that problem and kind of learning that space, you will naturally think about all of the kind of extensions and generalizations, or maybe challenging kind of practical, challenging kind of OR problems that could be motivated from this. And I'll give you a very concrete example here. These volunteer responder apps, right? Again, a lot of it was started kind of from this community, the very kind of practical resuscitation community, thinking about creating like rules for how you dispatch responders. Some people say, let's alert the closest 3 people to a cardiac arrest. Let's alert the closest 10 people. Let's alert everyone in a 400-meter radius, right? And then they'll come up with these ideas, and then you could potentially simulate or evaluate them. But then that got us thinking, like, well, what's the optimal like kind of alerting policy? Well, this sounds very much like an MDP problem, right? And then so subsequently with this student, we kind of worked on a much more kind of mathematically, kind of theoretically oriented version of this problem that will still give you insights, but of course the timeline is very different. And so I think for OR people like us, we want to try and have our feet in both worlds and try and do both, because you want to be able to solve the kind of practical problem that they're interested in. At the same time, I think you also want to look for maybe more challenging kind of OR modeling problems that will give you insights that you wouldn't get if you only kind of solve the practical problem.
Thanks. That's a very wonderful response. So I don't think there are any more questions. An anonymous attendee says, as someone who just learned basic concepts of optimization and queuing, this is super cool to learn about. Thank you for sharing.
Okay, thank you.
All right. So I think I don't see any more questions in the chat or comments. So I guess we can all give some a virtual round of applause here, and thank you for your time on a busy Friday. I'm sure the semester is coming to a close. So yeah, thanks again for your time. And this recording will be posted on the Informed Haas online seminar webpage. So if you know anyone who's interested in viewing it but was not able to make it, they can certainly come and watch the recording. So, thanks, Tim. Appreciate your time.
Okay, thanks everyone for being here. Thanks for organizing.
Thank you, Tim.